Good afternoon or good morning, depending on where you're joining us from. Thank you for being here for our discussion on the intersection of housing and health as part of our Discovery, Service, and Justice lecture series, which is part of the work that we do here in the Office for Culture and Community Engagement here at Harvard Medical School. Uh, Inspired by the 2025 Boston Public Health Commission's Community Health Needs Assessment, we're hosting our Discovery, Service, and Justice lecture series over the four critical themes shaping the community health needs assessment. Housing, specifically looking at affordability, quality, and homelessness; economic mobility, including income inequality and employment; healthy food access and food security; and access to care. In alignment with Harvard Medical School's mission to alleviate suffering and improve health and well-being for all through excellence in teaching, discovery, and service, each session will foster dialogue around systemic forces impacting individuals and communities. Before we get started, just a few housekeeping notes. The chat is not available and all microphones will be muted except for the speakers. Please use the Q&A to post questions for the panelists. And the webinar is being recorded and will be posted on the OCCE, or Office for Culture and Community Engagement website. As we get started, there are a few rules for the road to guide us through our discussion today. They are on your screen now. Please take a look and review these as I introduce our speakers. So our speakers today are Dr. Diana Hernandez. She is a climate fellow at Harvard Radcliffe Salata Institute and an associate professor of social medical sciences at Columbia University. She is a pioneering sociologist who's advanced the concept of energy insecurity through innovative mixed methods research, community partnerships, and policy interventions. She is the lead author of Powerless: The People's Struggle for Energy, the first book on energy insecurity in the United States. Having established foundational research in the area, she now focuses on research translational efforts with current projects, including cited Uniting to Reduce Energy Insecurity Initiative, statewide measurement of energy inequalities in New York, and energy insecurity screening, and links to various health outcomes in clinical settings. Next, we have Dr. Anthony L.T. Chin, who has been the director of the second largest health jurisdiction in Washington for the past 15 years. As chief health strategist, he implemented policy and place-based strategies, including health in all policies and health impact assessments, participatory budgeting, and health and comprehensive plans in multi-county planning policies, and collective impact through place-based multi-sectoral collaboration. And also of note, Dr. Chin is an alum of the Commonwealth Fellowship in Health Policy Leadership. And then last is Dr. Douglas Judy. He is a pediatrician and health disparities researcher who works as the deputy director launching an initiative connecting science community affiliated with Harvard Center and Developing Children. The program is focused on how investing in neighborhoods can reduce harmful stressors that negatively affect young infants and their families, thus leading to healthier development, less chronic disease, and greater health and opportunity. Prior to this role, Dr. Judy was a professor at UC Berkeley in the School of Public Health and founder and executive director of a national nonprofit called Build Healthy Places Network that focused on supporting healthcare and hospitals and partnering with community development investment field. So thank you to our wonderful speakers. Before we get started, I just wanted to make a quick comment about why we're having this focus today. Obviously, we're focusing on the intersection of housing and health, which is an issue that has been deeply rooted in the history and continues to shape health outcomes today. Housing is more than shelter, it's foundation for health and well-being. Unfortunately, in Boston, while it's a relatively safe and stable housing market, it has long been unequal in who has access to high-quality housing. With today's challenges, we need to look back at the policies that have shaped our neighborhoods, ranging from homeowners loan corporations that created redlining opportunity, redlining and misaligned opportunities for Black and immigrant residents, leading to disparate loans and investment in communities. This led to places such as Roxbury, Charlestown, Chinatown and Dorchester, among other neighborhoods, being impacted and having lower property values and less likely to have investment from the city because of that. Fast forward to look at Boston today, we're seeing housing crisis, much like what the rest of the country is seeing. Many people cannot afford to live in Boston because of the cost of housing and recent challenges to laws such as the MBTA law for um, equitable and fair housing in some of the suburbs has drawn a lot of contention from some of the neighborhoods that surround Boston. So we're dealing with this from issues, not just looking at it from the city of Boston, but I think it's helpful to ground this discussion as to what's happening in the city of Boston. And so my first question is going to go to my colleague Anthony. So this community health needs assessment emphasizes neighborhood level disparities in housing and health. How can local health departments effectively integrate housing stability into their health equity strategies? Specifically, how do social, economic, and environmental conditions affect health and health inequities?
Well, housing is one of two social, economic, environmental conditions that affect health that can kill you right away, right? I mean, um, if you can die of exposure, heat, or violence if you're unhoused. But that said, in public health, it is always important for us to focus not just on the kind of chronic end stage of homelessness and to move from tertiary prevention of homelessness to primary and secondary prevention of housing insecurity and housing instability, right? And the other tenet in public health, it's also important to move from individual impact to population impact. So when you think about the key functions of public health, first is assessment. Using U.S. housing policy tends to be guided by the point in time count, which I think we all know hugely underestimates homelessness and largely does not capture housing instability. So locally, I've advocated, for example, for using school McKinney-Vento Act data. Schools know which kids are sleeping on couches or sleeping in cars, and that is a better, still not perfect measure of housing instability for that population. And often school-age kids come with parents, so at least you capture families with kids. Another approach is to count encounters with homeless service providers. Again, that's kind of a small sampling, but it gives you a larger sample than the point in time count. So, and then the second key function of public health is policy development. So, Alden, as you mentioned, when I directed a health department, our four county health departments were very involved in comprehensive plans, right? So we really put health in comprehensive plan updates and multi-county planning policies. For those of you who are not familiar with that, it's like every metro area has something called the MPO, Metropolitan Planning Organization, historically started to, channel transportation and highway funding, but then have really become the organizations that develop growth management and development. So when you are able to work with those organizations, not only you're working on kind of very large, again, often multi-county policies, but you're working with partners everywhere from, commercial interests, local elected officials, environmental people. And it's a good way to develop partnerships as well as to have system-wide policy impacts.
It seems like addressing the housing issue is an all hands on deck type issue. And I think we often look at housing in what's the public health term that we love to use? Silos. We look at
Mhm.
housing as its own distinct issue. And what you're talking about is really how do we get multiple players to the table to really think about a complex health issue and a complex social issue.
Mhm.
One of the areas that I think is important, especially in the work that you do, is that you work a lot with immigrant communities. And despite everything that we're hearing with the rhetoric that's coming from parts of our federal government, immigrant communities are still vital to our country and to our well-being. But they have disproportionate issues, specifically when it comes to housing insecurity. Can you talk a little about what opportunities are there to mitigate some of the risks that these most vulnerable communities may be facing when it comes to housing insecurity?
Well, despite all the negative talk about immigrants, there have been lots of studies that have shown that many of these cities and towns, if it were not for immigrants, they would go under, right? I mean, there are only a few places like New York, LA, San Francisco, kind of world-class cities where the population, there's always a positive influx of population in those areas. But cities, I remember hearing a great case study about Dayton, Ohio, and also there was, I can't remember that place in Ohio where there was that whole issue around the Haitian immigrants, right? Those towns and cities would no longer be in existence if the immigrants had not come in to drive the economic engine and buy up the homes. So we have to remember that immigrants are so important to the vitality of our communities. That said, immigrants have certain issues. Well, I mean, they often have more traditions around multi-generational families, which is good, right? I mean, in the US, people tend to live in isolation, so issues around social connectedness, social support tend to be better in immigrant communities until they become Americanized, right? However, immigrants often have issues and barriers around language. They're often a lower income, especially when they first come in, unless they come in on one of these visas where they're highly educated and skilled. They often have a lack of understanding of laws and rights. And as you alluded to, it's becoming very much a risk now is their immigration status, right? So all of these are barriers and makes immigrants subject to exploitation. Again, a little different if they're, the college educated tech workers coming in on special visas, or those who are coming in on, the investment visas, right? But then also, as I said earlier, many of them being lower income and, in the needs assessment, that you mentioned, Alden, there's this affordability crisis. So where do you live if you're lower income? Further out, right? So I remember one of our mayors used to say, you live as far, you move as far out as you can afford, right? So what does that mean? That means these people have longer commutes. They have fewer economic opportunities where they live. They have to commute to the economic centers, right? So that means they have even greater costs, right? The rich people can live in a condo downtown, but the people who clean their homes live somewhere way out and they're spending hours of time. And of course, that impacts their home, their family interactions and so on and so forth. Immigrants also often move into marginal housing and neighborhoods because it's better than where they came from, right? And but it's these may be less desirable for people who grew up in the U.S. And then not only are there crime and environmental justice issues, but if those areas get developed, who gets displaced, right? They're the people who tolerated those lower quality housing. But someone comes in, builds a nice mixed-use development or a subdivision, those people get pushed out even further. So, how do you deal with this community then, right? It's so important. I mean, any public health work that we do collective impact through place-based multi-sectoral collaboration. That's a fancy way of saying you find everyone who is willing to talk to you or has interest in this issue, and you work together. So, immigrant communities is especially important to connect with community-based organizations that serve immigrant refugee communities, but also serve low income, the unhoused, so on and so forth, right? Or like legal justice assistance programs. Um, and then what I said earlier about moving for individual population impact, remember, if we were to do health and all policies or do health impact assessments, we're not calling out these communities per se, but whatever improvements we make and policies that then kind of guide how people work with everyone, it's everyone, right? So um, it can narrow the disparities that people are suffering. Some of the other things that we did when I used to run the health department was participatory planning and budgeting. This is a health equity strategy used globally. And that's where you actually give the community a pot of money. They decide how they want to spend it. I mean, often you supply them also with data around assessments and so on, but then you really engage them in voting on the options that they come up with. And then there is something that we were doing, and this is a little bit more granular. So there's healthy housing policy you can do, and I know that one of our cities here, Lakewood, pioneered doing this housing inspection. So, for low income housing, they make their money by just churning those homes. Someone moves out, they just replace it, which means the housing never gets repaired. So they would tell me all kinds of stories. They would go into, do it before the landlords can rent out, they had to get it inspected. So they would go into these places and they'll find things like, I mean, we're in an earthquake zone. There'll be like furnaces that had not been like strapped to the walls or, mold and stuff like that. But because there's this requirement for them to inspect the housing, that means that it becomes healthier for the renters. So, I mean, so many other strategies I'm sure people can think of, but these are just some of the things that health departments can work on.
You hit on a couple really interesting points with your answer to my question. And I just want to highlight a couple of my thoughts that I was hearing. Specifically, you mentioned about you live as close to, the city as you can afford. And you think about what's happening with specifically here in Boston with the MBTA Act and some towns actually being resistant to having mixed use housing, condos, more affordable housing available in neighborhoods for different communities to come into. So I think it's an interesting thought about people having to live further and further out away from the city center where their employment is. And then if you think about the way cities like Boston are structured, there's lots of individuals that are able to move to certain neighborhoods within the city of Boston for affordable reasons, but they also have worse transportation opportunities. So they're not near subway train stations and they have to use the bus and things along those lines. So it's not just that you live further out, but what you get with the type of neighborhood that you move into also is a part of this discussion. And then the last point, it just makes me think about what's happening in Miami, as you talked about gentrification and the way neighborhoods are changing. There's an area in Miami called Little Haiti, which is a thriving immigrant Haitian population. However, because of where it's situated in the city, higher elevation, less prone to flooding from hurricanes and other natural disasters, it's an area where there's more development happening, and an immigrant population is potentially going to be pushed out and displaced because developers see this as a place that they can get their hooks in and change the community without thinking about where those community members may go. So lots of great points. I guess my one last question to ask, and you started to get into this about some of the policies that have been enacted by the towns, especially with you being in a hurricane, excuse me, a earthquake zone and furnaces not being strapped down and having housing inspections. What are some other ways that cities or towns can think not just about the funding for housing, the cost of housing, but also ways that they can introduce legislation to help support so that there's those individuals from lower incomes can afford to live in safe, clean, affordable neighborhoods.
It's so important, like if you want to build housing, that you look at multiple sources, right? So, maybe Doug can comment on this. I know Doug mentioned he worked for Mercy Housing, but you have to braid the funding, right? And one of the strategies I tried to do here, which wasn't real successful, but has happened at other places, is, for example, to get hospitals to build housing. It's been clear that if you can, I mean, Alden, you work in the ER, you know this, right? That when people are unhoused, they're in the ER all the time. And no one wants that. And the hospitals are losing money on it. So it's been shown that if you stabilize them for even 60, 90 days, and it doesn't have to be permanent housing, you stabilize and then, oh, guess what? They get their insulin back, or they're reconnected with their substance use abuse treatment program, right? So looking at alternative partners is really important. Some of the more innovative things that we've looked at here is community land trusts. I know they've been around for a long time, but it hasn't I think people still kind of think of it more like, hey, that was kind of like a hippie thing to do. But when you think about removing the cost of land from I mean, those of you who have homes and you're paying property tax, right? There's the land costs and then there's the building costs. Think about if we remove the land cost, how much the price of the house would go down and how much your property tax would go down, right? But then, of course, there are mechanisms to keep it so that someone doesn't come and buy it and then like sell it for a huge profit, right? So there are mechanisms where it comes back into the pool, and that's really important. You cannot have people like the hedge funds that come in, they buy up the low income housing and turn it into rental and they keep hiking up the prices, right? That doesn't work. And something which people have not really embraced here. And again, this is actually one of the challenges. I mentioned displacement as another challenge of like development and growth management is worker housing, right? If you go to like China, you see a factory and right next to it is a huge dormitory. Right here, it's because I mean, at the same time, we don't want to lose industrial lands because oftentimes unless industrial lands get encroached on by development. But what I said earlier about these people, where are they coming from? If you put housing next to factories or on factory grounds, now it's not perfect because it might, air quality, all that might not be great, but still, then, like in China, these people just get up in the morning, they walk, right? And so there's low cost for them. Now, I don't know how much they get charged for it, but that concept, or, all these mixed use developments, who works in them and who lives above them? Two different populations, right? It's affluent people living above the mixed use developments. The people who clean it don't. So what if you said for every mixed use development, you had to attach one or two units to it, which means that, sure, the manager of the Starbucks could live there, or they could let one of the baristas live there, or two baristas, or three, whatever, right? So these are innovative policies that are around the edges. But then also what's also very important is that it's not just the housing. You hear every politician says we just need to build, build, build.
Mm.
No, you can build as much as you want, but remember the other socioeconomic environmental conditions. If wages do not keep up with housing prices, tough. You build more homes, it just goes to the more affluent people, right? If you don't address the crime issues, tough. You build nice housing, but who's going to live there? Or are they just going to put bars up on the windows and, it's not really accessible to the community, right? There's no easy solution, but again, this kind of comes back to that collective impact thing, but then also be working on a systems population level and looking at innovative approaches.
Awesome. I want to thank you for your comments, and you actually gave a great segue for us to bring Doug into this conversation. Doug, you champion the idea of housing can serve as a platform of health, and Anthony was mentioning this in part in his answers. And so, what does it look like in practice? How can healthcare systems partner with housing organizations to improve outcomes for patients and for the community?
hmm Yeah, thank you, Alden. And yeah, Anthony had some really great points I can follow up on. A few things I'll mention, and knowing some of the audience, like I am a professor, so I like to give homework. So listen for your homework. So many of you may have heard the language of anchor institutions. So one of the critical ways that hospitals and healthcare systems can play a role, they are often some of the largest employers and economic engines, especially in smaller cities, but even in places like Boston. And the hospital systems you're thinking about. The whole idea of an anchor is that the hospital or healthcare system is anchored in place. This is also true for universities. They can't pick up and move somewhere else. They are stuck there, which means benefiting the community they're in benefits them as well. And so the shorthand is to hire local, buy local, and invest local. I tend to focus on the invest local because it is tied to housing and community investment. Boston's very lucky that there's a very strong network of healthcare anchor institutions there. And there's actually an national organization called the Healthcare Anchor Network, which is worth looking into. Boston, before we got on, I looked Boston Children's, Beth Israel Lahey, Boston Medical Center, Mass General Brigham, are all members of that organization. So they work together to try to actually follow through. So in terms of what the role healthcare can play, This is a lot of what I've been doing for the last 15 years, is focusing on how those partnerships can happen. First off, the community development, the community revitalization organizations were often not thinking about health as the work they were doing. They didn't see the connection. Just bringing that mindset to the work of the neighborhood revitalization folks can be really powerful because it's another case to be made for why the work they're doing is so important. It's also important to distinguish in your mind the bad developers, and there are a lot. Little Haiti, I've been to Little Haiti. It's actually a real problem. The for-profit developers are racing in. It's considered climate gentrification. But a lot of organizations are nonprofit developers. They actually protect against gentrification and displacement because they will build housing that is preserved for low-income residents. Interestingly, there are some mission-driven for-profits, which surprises people. There's also a lot of mission-driven nonprofits. And Anthony mentioned I was on the board of Mercy Housing, which is the largest nonprofit affordable housing developer in the country. They have $3-4 billion in assets, working in 25 states, housing tens of thousands of residents, all low-income residents. And it was founded by a group of nuns 40 years ago. And so they are just one. The Community Builders works in Boston. There's an organization called POA, Preservation of Affordable Housing, Urban Edge, all do affordable housing in the Boston area. But I wanted to here highlight, and this is getting to the answer partly because these are the types of organizations a hospital or healthcare system can partner with. It's not just housing. So affordable housing doesn't just come from the Boston Housing Authority or from Mass Housing. A lot of it is built through this network of community development organizations. There's two good acronyms to know. One is a CDC. That's not the one in Boston. It's the Community Development Corporations. There are, I think the last count I saw, over 4,000 CDCs across the country. These are nonprofits. They tend to do housing and other community development. Just in Boston, I looked this up. There's the Alston Brighton CDC, so ABC, DC. There's the Asian Community Development Corporation that started in Chinatown and now works citywide. Jamaica Plain Neighborhood CDC, East Boston CDC, Fenway CDC, Southwest Boston CDC. I love Inquilinos Borocuas and Acción is in the South End. And then Codman Square, some of you may have heard of, is one of the best known CDCs in the country, actually. They've been very comprehensive. There's another group of organizations called CDFIs, Community Development Financial Institutions, that are basically banks, nonprofit banks, if you will, that help bring the dollars together and would be really good partners for a hospital or healthcare system. Turns out Boston Community Capital is one of the biggest CDFIs. It's now called Blue Hub Capital, but there's a bunch of others. There's Boston Impact Initiative, Mass Housing Investment Corporation, Community Economic Development Assistance Corporation, all based in the Boston area. So those are ones you can look up later, but the point is they bring together different sources of financing. A lot of the money, and just to give you all a sense of this, I think this is exciting because hospitals shouldn't be trying to build housing on their own. They should be partnering with these organizations I mentioned, and they should be leveraging the dollars that already exist out there. And what surprises a lot of people is it's a lot of money. We don't tend to hear a lot about it because the money that goes into affordable housing community development tends to be tax credits, which doesn't come up in budget talks, and is legislative. So the Community Reinvestment Act dates back to the 1970s, requires that banks invest in neighborhoods that were formerly redlined, where they have a presence, like a branch, or have people that bank with them. The CRA, the Community Reinvestment Act, has been around longer than redlining was around. So it has driven a lot of money into the neighborhoods. I think one of the reasons we haven't solved poverty per se is because we tend to do it very transactionally and very short term. We just build housing. We don't build housing in the context of people's lives. Anthony was alluding to this. It's got to be more holistic. There's also these tax credits, low-income housing tax credit, new markets tax credits for jobs in low-income neighborhoods. So to your question, where I think housing can, or hospitals can play a role, there's several places. I name 8 of them. First is thought leadership, advocacy, clout. Overcoming some of the NIMBYism that Anthony was referring to is really powerful. Hospitals are an unexpected partner. Data sharing, that's the community health needs assessments. Help the affordable housing developers know where to build the housing, what type of housing. Community benefits and grants, we know that hospitals have to do that. Programs and services, and not just healthcare services, things like IT support for local nonprofits, accounting support for local nonprofits, co-locating services. And then it gets really interesting, and this is sort of another conversation, but hospitals, nonprofit hospitals have big investment portfolios. they could use some of their dollars as low interest loans or a loan guarantee, or directly using the real estate they own to allow housing to be built, to lease it, to lend it, to develop it, to swap for other property. So there's a lot of opportunities there for hospitals and healthcare.
So it sounds like, as you're mentioning, all of these opportunities that are available, it's that hospitals need to be proactive in this space, but don't necessarily need to be the ones building the housing, but
Right.
working with the community, which is often where that disconnect happens. And I think with a CHNA, and I know my hospital has done their community health needs assessment every 3 years or however often they're required to do it. There's these things that sort of just get put on the back burner or don't get added to the report. I think this is a very obvious one that should be included in every
Hmm.
community health needs assessment. And really, institutions need to think about how they can not only support the individuals that come to the hospital as patients, but also their employees who, as Anthony mentioned, would have to travel very far to come to some of
Right.
these
Exactly.
institutions because they don't have the opportunity to live near
Mhm.
near the hospitals because the cost is usually so high around those
Yeah, it's
types of.
workforce housing
Yeah,
is often an entry point because that's very much of interest to a
yeah,
big institution.
yeah. I don't want to discount the fact that you are a pediatrician by training. And so a lot of your interest in this area has come from the experience that you've had as a clinician caring for patients. Can you talk a little bit about just helping us to set the stage, the impact of child health and housing, and then
Hmm.
also maybe how you view stories from your patients to come up with solutions
Hmm.
that may seem promising to address some of the housing issues that we're facing.
Hmm. Yeah, no, thank you for that. Yeah, so my focus, well, I'll mention answer the last question first, is it can be really powerful for the clinicians in the audience to use their personal stories. And so when I first started this work, one of the most effective ways of getting the attention of policymakers or frankly skeptical hospital administrators and others is to talk about the experience of a personal patient. Mine would be a child, who I had kids who had chronic lung disease because they had been born preterm. They were struggling with their getting pneumonia at home, and then I find out from the family that there are broken windows in the home. So I spent a lot of time. My first job was in a low-income community clinic. I was writing landlords letters to get the carpet out for asthma attacks that was taking the parents to the emergency room, trying to get transportation for kids to make it to medical care they needed, getting these windows fixed for the kids with chronic lung disease. And so those can be really powerful first steps. But, and this is again related to Anthony's points around we've got to step back because the impacts of unaffordable housing or frequent moves or intermittent homelessness is really more fundamental. It gets really to the root of your development, especially in early childhood. I mentioned earlier connecting science and community where I'm working. Our focus is really around excessive stress activation, which is really the most general way. We use the language of toxic stress. We're trying to kind of stop thinking about it as the stressor, the toxic stress, and rather it's the toxic stress response of the body reacting appropriately to the experiences they're having. And we're over at CSC, one of the things we're working on is what we call the HERO measures. So it's HERO stands for Health's Early Roots and Origins. This is a new work focusing on 18 biomarkers, measures of executive function, parent questionnaire to get a sense of their socioeconomic status. How can we get at a neighborhood level a baseline of how the families are doing? And would be true for affordable housing and show how that improves over time. And it actually is measures of resilience. And it's not just like cortisol, it's telomere length, it's endocannabinoids that I'd honestly never heard of before, which is a measure of resilience. And these known factors drive both cognitive development and lifelong health and chronic disease development. And so, to your question around upstream solutions, in many ways, the different interventions we're talking about really are about reducing the stress the families are under. And young children in particular are usually safe in their home, especially the very small babies. So you have to think about the parents. The parents are coming home overloaded with the stress of their day, transportation, the economic situation they're in, the job availability. And housing, of course, is critical because you need safe, stable housing, but it alone doesn't do it by itself. It's also really important to start early and as I mentioned, think about the parents, not just the babies. And so that's one of the things we're working with some of the community organizations is how do you intentionally target babies and young families? Not that they're more important than the elderly or that those with disabilities. It's that the biology is going to embed their experience
Mm.
at that age in a way that doesn't happen when you're older. And if we can get those kids into early adulthood, they'll be on a path to of opportunity to choose where they want to be later.
It's interesting as you were talking, I was thinking of, housing and ACE scores, average childhood
Yes.
experiences. And while housing isn't, from my understanding, included in the ACE scores, it sounds like it's, just as important and should be up there as one of the things that we are thinking about. And we have this number, this metric, this tool to look and to calculate an ACE score. But I don't know if we necessarily have embraced housing in the same way, especially because we think kids are resilient. We often
Right.
think, kids will bounce back. And the reality is, as you were mentioning it, they're experiencing the stress, and they are responding to the stress. Thank you for helping us to think about it that way,
Mhm.
in a way that is going to have long-term health effects. And you mentioned telomeres and then other things. Yeah, I think we're stepping a little bit more into the science realm than we may need to. But I think it's really interesting just to hear that discussion going further. Um, One last question for you, because both Anthony, former practicing physician, you a former practicing physician. What are the lessons that we can take as physicians and other healthcare workers and bring to the table when we're trying to talk about the importance of stable, affordable housing conditions, especially as we're trying to advocate for our patients, and whether that be in the clinic as some of the efforts that you talked about with writing letters, or maybe even taking that step outside of the clinical practice and doing some of the work that you're doing.
Yeah, absolutely. And one ACEs are a great one. Adverse childhood experiences. The concern I have about ACEs is it requires the child has already experienced that adverse
That's true.
experience. I want to avoid that. And housing is often, as you say, it's the stress of living in poor quality housing or moving a lot that results in the divorce or the physical abuse or that are the ACEs. And so
Mhm.
you want to start early. You want to think about what is it that's setting families up to not be able to support their child as much as they want. And that moves you a little bit further upstream. I think the biggest thing with thinking about doctors, healthcare providers of all types is that we have a voice that is respected in a world that there's not a ton of respect, and certainly healthcare has taken its hits, but it's often both a respected and unexpected voice speaking to this. How we provide expertise in connecting the health, as I mentioned, but there's a value, and in fact, I'll mention this is, and I say this only because I have done a lot of thinking about this. There's an article I published a couple years ago in Academic Pediatrics that you all can look up. It's called Neighborhood Poverty and Child Health: Investing in Communities to Improve Childhood Opportunity and Well-being. I'll mention a couple of the things that I conclude there about our role as clinicians and healthcare providers. But I think the easiest, honestly, is we are talking here about the CHNA that the hospital systems in the Boston area have done. Keep in mind, there's also the Community Health Improvement Plan that is supposed to come from the CHNA. This CHNA does an amazing job of highlighting housing as a critical issue. My experience, and this has been documented, up to 80% of CHNAs mention housing. Very few of the community health improvement plans mention it because no one knows what to do about it. And as I'm mentioning, there's a lot of opportunities, whether it's the political clout, the services, the real estates, the investments that hospitals can do. So hold your healthcare system to account. If they mention it, say that they don't have to do it themselves, partner with others. And for you yourself, think about, I put it into four boxes, and I will just mention a couple highlights, but education and raising awareness, engaging and advising, advocacy, and research. So education is bring some community development experts to come speak at your grand rounds, at your clinic, at your hospital setting. I'm a part of the American Academy of Pediatrics. Bring them to a local meeting, incorporate these ideas into the curriculum, whether it's medical school residents. There are mapping tools out there that you can use. Raj Chetty, who's based at Harvard, has the amazing Opportunity Insights. You can find out a lot about the neighborhoods where you work and where your patients come from. My old organization, Build Healthy Places Network, has a ton of stories and case studies that you can learn more about these opportunities to work together. We highlight exactly the topic of today's discussion around healthcare and community investing. The engaging and advising, I've been on boards now, many different community development and affordable housing boards. It's super exciting. They want smart people to engage. They like the additional perspective, work to make sure that community developers are coming to your local CHNA planning and work, and make sure that those connections, these community development organizations are seeing what the CHNAs say so that they actually hear that. Advocacy, same thing. Advocate for the anchor institution role, advocate for local policy change. And then the research, really, there's money out there, as I mentioned. The money doesn't know where to go first. Is it housing? Is it a grocery store? Is it both together? Should there be a child care center there or not? There are natural experiments out there. That $500 billion a year is going into the ground, whether researchers look at it or not. You can begin to look at different cities and different types of investment and see what are the short, medium, and long-term health consequences so that our colleagues can help make better decisions.
So it sounds like all of the above. There's opportunity depending on what you're interested in, and
Yeah, yeah,
getting
exactly. It should
involved.
really like not some people don't do research. Some people
Yeah,
prefer to be advocates, other people don't want to be advocates. Absolutely. I think there's a
yeah,
lot of different
yeah.
opportunities.
Yeah. And I just want to just anchor in on the point that a lot of these community organizations are looking for board members, and the physician perspective is always valued. They don't know how to get in touch with us. They
Right.
often, and so just make yourself available. I think if you want to be involved, your physician perspective is going to be greatly appreciated. Thank you, Doug, for your comments. I want to bring in Diana, because Diana is going to bring in an interesting angle that we often don't talk about most of the time because we haven't actually started to really understand what's happening with energy insecurity and housing insecurity. And so, Diana, your research highlights energy insecurity as a critical dimension of housing quality. First off, can you explain to us what this intersection is, especially in urban areas like Boston? And then also, what are potential consequences if we aren't looking at housing and energy security at the same time for these vulnerable populations?
Yeah, first of all, let me just say thank you for having me, and I really appreciated both Doug and Anthony's comments earlier. Doug, I haven't seen you in so long; it's really a pleasure. And also, let me just kind of qualify that my response in saying that I'm a sociologist, and in that sense, I'm very different than the prior speakers because I really do come to this work as someone who is looking at it from a social science perspective. And a part of what my kind of academic scholarship has been about is offering frameworks to understand how things work. So one of the things that paper that we wrote and is pretty heavily cited around housing dimensions, is looking at what are the aspects of housing that impact health and health equity. And they really are like four pillars: costs, conditions, consistency, and context. And so the costs obviously have to do with affordability. The conditions, that's more wide ranging, and that could be about the physical conditions of housing and exposure to lead and mold and asbestos and energy insecurity, which I'll get to. Consistency, which has everything to do with whether or not people can actually live in their homes for periods of time on a voluntary basis, or whether or not there are these push and pull factors that might determine how far away people might live from the city center, for instance, but also whether or not those conditions are pushing people out. And then the context, and that has to do, like the Raj Chetty's work, as Doug kind of pointed out, is really about the neighborhood opportunity structures and amenities that set people up for health. And usually, I mean, affordability and, like safety concerns and these kinds of things, there's this whole dynamic. And, within those pillars, people are making decisions about what works for them and what's necessary and what are the kind of constraints around their decision making. And it was actually in Dorchester. So I'm a New York City native, and I sound like it, I know. But I learned all about energy and security issues having done my dissertation research in Dorchester. I was looking at the Medical Legal Partnership, which is based in the Boston Medical Center. And I developed this dissertation project around housing and the relationship between housing and health, and how legal services provided within clinical settings in federally qualified health centers could mitigate that relationship. And some of it was about, doctors writing those letters for shut-off protections and to address and mitigate housing conditions issues. But it was also just sitting in people's homes in Dorchester and seeing my own breath in a really cold home, or seeing kind of how people were navigating their energy and like natural gas and fuel oil kind of systems that helped me to realize, oh, there's something going on. And it was actually sitting in someone's home in BHA in Boston Public Housing that I realized this is not just about costs. So much in the same ways that we'd kind of characterized housing as like these four pillars. Energy insecurity is defined as the inability to adequately meet household energy needs. There are three dimensions to it. There's the affordability, there's the physical housing conditions, inefficiencies, deficiencies, increasingly outages related to electricity loads and things like that. And then coping, all of the different ways that people are coping under the circumstances of these financial constraints and the physical realities of their homes. And when we think about again like these tensions between affordability and conditions, one of the things that comes out in some of the more recent work, including the book that was just published, Powerless: The People Struggle for Energy, is that people are leaving their homes, they're leaving their homes as in like for periods of time when it's really hot or really cold outside and they can't necessarily manage indoor temperatures. They're also restricting how much of the space they're using in their homes by basically heating up one room. Or they're moving as a result of these energy insecurity issues, actually more so than seeking energy assistance. And when I think about the relationship between energy and housing, what I'm really thinking about is the hardware, which is housing, and the software, which is what makes housing operational and livable, and that's energy. And when we think about then the health consequences of energy insecurity, it comes up in two ways. One is that chronic illness and living with different disease conditions actually makes people more susceptible to energy insecurity. So it is a precursor or um, a determinant of energy insecurity. And that actually is very different than most of the social determinants or the drivers of health, right? And so people that are living with cardiovascular conditions, mental health conditions, respiratory conditions, using electronic medical devices, we found in New York City they're all more likely to experience energy insecurity. At the same time, energy insecurity leads to food insecurity, poor sleep, troubles managing respiratory health conditions, mental health conditions also appearing, right? So it's this kind of very close-knit relationship between energy and health. And I want to say that there's another piece to this, which has to do with the relationship between energy insecurity and housing insecurity. And I like to kind of sum it up as today's disconnection is tomorrow's eviction.
Mm.
And we've paid a lot of attention to the crisis point of housing insecurity, which has to do with like basically people being evicted and therefore displaced as a result of these affordability challenges. But oftentimes before they kind of get to that place, they're making trade-offs. Folks are making decisions between paying one bill and another. There are these kind of seasonal relationships between that. But the truth is that when people are reaching an energy crisis, so they're, in at risk of or living through a shutoff due to non-payment. That is often when people are having to make a lot of different decisions around the allocation of resources and prioritizing energy, and therefore then falling behind on housing costs. And so these are, they're really interconnected. But it's much cheaper and much easier to deal with the energy issues than it is to deal with, a family that has been displaced. So that's a lot of ways of kind of getting at this relationship, but it is one of those more hidden ways in which housing becomes untenable and unlivable in many ways. When it's too hot, when it's too cold, when, the lights are out, because of a disconnection or because of the increased challenges in putting food on the table or basically maintaining shelter.
Thank you for that answer. I think it helps to put some context to what you were saying and the way you were describing it. I just want to point out one thing, and that is New York and Boston can get along, and it's through Dr. Hernandez and her research and work, you can see that the two cities can get along, even though there's a lot of rivalries on the sports fields. And secondly, I think you brought up something, and just harkening back to what I was just asking Doug about. You mentioned this as a sign of an underlying problem. And I can tell you that right now in the Northeast, we're dealing with this quote unquote polar vortex, which means it's really cold outside. And I recently had an elderly couple in my emergency department because elder services went to check on them and there was no heat in their house. And it's an elderly couple. And they came to the emergency department. And so if you just think about this, the only need that they didn't have any health needs, but the emergency department became the place where they had to go. And Anthony mentioned this, Doug has mentioned this, and now you're mentioning this. And we're failing as a system, and we see it as the stressor on the hospital. So thank you for that introduction. Sorry for my additional comments. Based on your experience with community-driven housing redevelopment projects, um, what policy levers or local interventions have been proven to be effective in reducing some of these issues that you mentioned and helping to address some of the health disparities that we see because of this issue of energy insecurity?
Yeah, well, first of all, you never have to apologize for telling a good story. I think basically that's the essence of it, right? That, we're basically because we don't have a good safety net, it's some of these other anchor institutions, as Doug was kind of alluding to, that are really kind of picking up the slack and also receiving literally on the receiving end of care and trying to provide care in different ways for social needs. So on the revitalization side, let me just say that first of all, I've literally like um rehabbed buildings and with three gut renovations and have learned so much as a result of myself being kind of a housing practitioner. But there are definitely city level policies that are really critical. One, I would say is around heating ordinances and cooling ordinances. So there has been kind of a long-standing in housing codes and building codes in many cities, like there's like temperature regulation for winter time and the provision, like ensuring that there are minimum indoor temperatures. And that has been really helpful, but you have to actually do enforcement. The enforcement mechanism actually, and we're proposing this in some guidance to New York City, is a signal, is a place where people are calling about no heat, they're complaining about it. It's an opportunity for city officials to actually see what's going on in homes, but it isn't often the place where those building owners and operators are being channeled to services. So they might be penalized, they might get a violation, they might, like whatever, but that's often a place where there could be a little bit more directed resources and helping navigate those systems. And I think this is especially true for housing operators that are providing services to low and moderate income tenants on the rental side. The other piece that I've noticed is that it's not just about the rehabbing or the retrofitting of buildings, but that what actually is kind of increasingly necessary and a blind spot is in the maintenance and property management. So one of the reasons why you even have buildings that were recently renovated, but they fall into kind of these other issues around deferred maintenance is that they don't have a regular kind of, and I'm not talking about large buildings, I'm actually talking about small buildings, the 2 to 4 families, which is where we see energy insecurity surfacing most in New York City. Um, I'll keep my answer short there, but definitely it's partly about identifying the sites and the buildings that are presenting with issues that might not otherwise show up, but their tenants are calling because of no heat. And the other piece is like, what are the mechanisms that allow for not just the renovations? That's important, especially in cities that have older housing stocks, but in kind of the ongoing maintenance and management of those properties. First of all, to maintain them as affordable housing sites, but also to ensure that the quality is still there.
So I think what you were saying sort of also ties back into what Anthony was saying is the importance of having the laws and regulations in place, whether it be for new buildings, retrofitting old buildings, or just keeping up that maintenance on some of the places that are considered lower income or quote unquote affordable housing to make sure that the people that are in those buildings have high quality housing and affordable housing at the same time. In the interest of time, I do have one more question for you. We could hopefully keep it brief because I want to try and open up for questions to our audience. And I know this is a complex topic because we're talking about climate change. Um, it's intensifying energy burdens. How do cities like Boston, New York, and other cities think about housing and energy equity as they start to plan for the impacts of climate change and they're thinking about the health of the residents of those towns and cities?
Yeah, I will say that the big part of it, I mean, in Boston and in New York, there has been so much emphasis on heating, not enough emphasis on cooling. Thinking about ways that, residential units should be equipped with some cooling options. That's important, but also reforming and expanding energy assistance. So right now, with whatever, like all of the things that are happening at the federal level, which, would take a whole whatever to get into cities and states are actually like need to do more around energy assistance and thinking about what policies are in place to support people, residents, especially in warmer weather. And I would actually just say that another piece of this is that cities are not tracking energy insecurity. They're tracking food insecurity, they're tracking housing insecurity, but we really need more public health surveillance around energy insecurity. And we need that in clinical settings as well. So in city-owned hospitals, like how are we actually identifying patients that are presenting with these issues? There are social care needs screeners. Underreporting is a big issue, but if we're not measuring it, it's really difficult to monitor it, and it's really difficult to also assess any progress. Especially when it comes to policy interventions that are meant to support households. But I would say, thinking about, of course, like, clean heating policies, but also air conditioning. So anything that is reducing air pollution and greenhouse gas emissions is really critical. A lot of that is in the residential, commercial building space, but also thinking about how do we track the problem and monitor progress.
So thank you for that. I did see that there was a question in the chat for Doug, and it sounds like you've answered it. But Doug, just quickly, how you're measuring allostatic load and toxic stress in your patient population.
Yeah, hi. Yeah, so I would have the group. It's a standard protocol. It's in young babies up through age 4, but it's a cheek swab, saliva, and a snippet of hair to capture several different realms of things like cortisol, endocannabinoids, epigenetic markers, and others. It's still in the testing phase at the community level. It has been standardized, but we don't yet have it normed for individual use. It was designed initially for pediatricians to use, but that's going to take a while. And there's the opportunity potentially, and we're working with Spartanburg, South Carolina, and Atlanta, and probably Omaha, where the local leaders, and this is important, the local leaders want to have more information about how stress-inducing or not stress-inducing their different neighborhoods are to help them use that information to help drive investments and decision making. So it's still sort of in development in terms of its use, but it's non-invasive and it's driven by the community.
Awesome. It's good to hear that community is interested and also the leaders of the community are also paying attention to this. And I think that was a point of what Diana was trying to make is
Mhm.
the community has to be listened to in their experiences and leadership of the community has to be engaged in this space. I want to say thank you to our speakers, Dr. Hernandez, Dr. Chin, Dr. Judy. This was a great presentation. I feel like I learned a lot from the three of you bringing this discussion to the forefront. So thank you for your time. Lynn, I know we have one or two closing slides before we step away. So just a couple of tidbits for everyone who is joining in. We do have some programs related to our office, including a research opportunity for medical students. So if there's any medical students or you're working with any medical students, we have our visiting research internship program with applications due at the beginning of January. We will be continuing our Discovery Service and Justice lecture series with the next discussion on one of the pillars of the community health needs assessment. And we're going to discuss food access, food security, and health. So please join us for that on Tuesday, January 20th. And then lastly, we have our event as part of our collaboration with the Center for Bioethics here at HMS on bioethics and Black history, the legacy of the Tuskegee Report. So there is a brief survey if you all can please click and fill that out. Otherwise, again, I want to say thank you to Dr. Hernandez, Dr. Judy, and Dr. Chin for joining us. And thank you for Lynn for all the work that you've done on the background to help us to have a wonderful event. And look forward to hearing from you all and seeing you all in future events. Everyone, thank you and have a great rest of your day.